Welcome to the BC Technical webinar series. Today we will discuss radionuclide gastric emptying. This webinar session is worth 1 voice credit. In order to receive this credit, you must complete the online test, which will be available immediately after this webinar. A passing score of 80% is required for the voice credit to be awarded. You may take the test more than once if need be, and a certificate will be emailed to you at the close of this webinar and following successful completion of the online test. Please keep this certificate as proof of your completion of this webinar. Radionuclide gastric emptying and motility imaging is a physiologic way to evaluate function. This program is a review of the Society of Nuclear Medicine and Molecular Imaging, American Neurogastroenterology and Motility Society, and the American College of Radiology consensus guidelines for measurement of gastric emptying. These non-invasive studies use a meal, solids with or without liquids, and are quantitative. Serial testing can follow the effectiveness of treatment. Standardization of this procedure will ensure comparable results between institutions. The 2015 published consensus guideline on the scintigraphic measurement of gastric emptying in adults by the SNMMI and ANMS is supported by the ACR, American College of Radiology, and will be discussed later in this program. Liquid phase gastric emptying studies have not been used for some time since it was believed that abnormal liquid gastric emptying was a late phenomenon and a solid meal would detect abnormal gastric emptying better than a liquid meal. Recent studies suggest that liquids may detect some patients with abnormal gastric emptying when solid gastric emptying study is normal. There are, however, no consensus recommendations at the present time on the best liquid phase gastric emptying meal or protocol. Gastric emptying can be used in the evaluation of obstruction, nausea, vomiting, weight loss, abdominal discomfort, early satiety, and GE reflux or chronic aspiration. Contraindications are as follows. Pregnant or breastfeeding women must be excluded in accordance with the institution's policy, and appropriate radiation safety instructions must be adhered to. If the patient is allergic to eggs or any component of the meal. Blood glucose levels that are less than 40 milligrams per deciliter, or blood glucose levels greater than 200 milligrams per deciliter. Recent nuclear medicine procedures, radiopharmaceutical dependent, may also be a contraindication for this exam. The stomach functions as a storage and mixing chamber for digestion. The digested food is then propelled into the duodenum. The stomach can be divided into regions. The proximal region, which is fundus, controls liquid emptying. The distal region, which is antrum, controls the rate of emptying of solids. Contractions in the proximal region create a pressure gradient to force liquid into the distal stomach through the pylorus. The distal portion churns and liquefies solids before they leave the stomach. Particles remain in the stomach until they are less than 1 to 2 millimeters in size. The pylorus helps break down large solid particles and restricts the rate of gastric emptying while preventing reflux back into the stomach. Gastric emptying is dependent on the volume of food and the density, which is the amount of carbohydrates and fats. Gastric emptying can be inhibited by hormones, such as cholecystokinin or gastrin. Rapid gastric emptying or dumping syndrome can occur after gastric surgery. Motility disorders can be mechanical or non-mechanical. Mechanical causes of motility disorders can be ulcers, peptic, duodenal, or pyloric channel, surgical, cancer, post-radiation therapy, or trauma. Non-mechanical causes of motility disorder can be metabolic, like diabetes, uremia, hypotension, hypertension, and gastroma. They can also be neurologic. Systemic diseases, such as scleroderma, smooth muscle disorders, and anorexia nervosa. Or they can be drug-induced, like anticholinergics or opiates. Patient preparation for gastric emptying studies is as follows. The patient should have nothing by mouth 4 hours prior to the scan. Prokinetic agents should be stopped for 2 days prior to the exam, unless the exam is to assess the efficacy of these drugs. The following medications are to be stopped 2 days before the exam. Opiates, antispasmodic agents, atropine, nifedipine, progesterone, octreotide, theophylline, benzodiazepine, and phentolamine. There are special instructions for patients with insulin-dependent diabetes. Patients should be instructed to bring their glucose meter and insulin to the exam. The blood glucose level is recorded before and after meal ingestion. The morning dose of insulin should be adjusted for the prescribed meal. The consensus guidelines describes a standard meal that consists of the following: 4 ounces of liquid egg whites or egg beaters, 2 slices of toasted white bread, 30 grams of jam or jelly, and 120 milliliters of water. The adult dose is 0.5 millicuries of technetium-99m sulfur colloid. The meal is prepared by mixing the dose of 0.5 millicuries of technetium-99m sulfur colloid into the egg whites in a shielded container and cooking it. While cooking, be sure to stir it once or twice until it has the consistency of an omelet. Spread the jelly on the toasted bread, and this can be eaten separately or as a sandwich. This is a picture of a standard meal. The patient must be instructed to ingest the meal as quickly as possible, ideally in less than 10 minutes. Recording is an important part of this exam. Record the time it took to consume the meal and if any was not eaten. 50% of the meal must be consumed to complete the test. If the patient vomits any part of the meal, this should be recorded and the test aborted. The acquisition parameters are a large field of view, dual head camera. A large field of view, single head camera may be used if a dual head camera is not available. The energy peak should be 140 keV, energy window 20%. The collimator should be a low energy, high resolution. Patient position should be supine or upright. Imaging begins immediately after meal consumption. Imaging is planar and the views are the initial. Post-consumption should be imaged after 1 hour, 2 hours, 3 hours, and 4 hours. Matrix size is 128 by 128, and time per view is 60 seconds per image. The reason for the 4-hour length is due to data from a 2-year study suggesting that delayed emptying is detected with higher sensitivity at 4 hours rather than at 2 hours. During imaging, you need to obtain anterior and posterior images, positioning so that the distal esophagus, stomach, and proximal small bowel are in the field of view immediately after meal consumption. Repeat imaging hourly for up to 4 hours post-ingestion. Imaging is complete when less than 10% remains within the stomach. These images are a 4-hour gastric emptying study acquired on a large field of view dual head camera. This is an example of rapid gastric emptying post-meal ingestion. This is an example of minimal gastric emptying. Normal values for food retention in the stomach of an adult were found to be 37 to 90% at 1 hour, 30 to 60% at 2 hours, and 0 to 10% at 4 hours. Follow-up studies should always be done under the same conditions as the original study. Same meal, collimator, and analysis programs should be used. There are some scan options that can be applied. A dual head camera is preferred, but a single head camera can be used if acquired in the left anterior oblique position. Using a marker is often helpful. Placed on the iliac crest, it is used for positioning from scan time to scan time, and also it can be helpful in placement of the region of interest. An alternate meal may be needed for patients who are allergic to eggs or gluten. Similar nutritional content should be used in this alternate meal. When processing a gastric emptying study, we need to draw regions of interest around the stomach. The region of interest should include the fundus, proximal, and the antrum, distal, stomach. The region of interest should not include small bowel. Typical anterior and posterior stomach regions are shown here. Calculations are as follows. Images are corrected for radioactive decay. Calculation of the geometric mean is done if possible. Both anterior and posterior images are required to calculate the geometric mean. The geometric mean is the square root of the product of the anterior region counts multiplied by the posterior region counts. The results are displayed as the percent remaining in the stomach at each time point. Total gastric counts are normalized to 100% for time 0, which is the first image taken after the meal is ingested. Time activity curves are generated from the geometric mean gastric counts at all time points in this study. This is an example of a 4-hour gastric emptying study calculated from the geometric mean. There are many sources of error in gastric emptying imaging. If the patient vomits after the meal ingestion, if there is poor labeling of the meal, if a non-standard meal is used, emotional fluctuations such as fear, anxiety, or anger, or nausea caused by a meal that may be unfamiliar to the patient. Other sources of error can be a patient who has eaten just before the study, slow movement of the ingested material from the mouth or esophagus into the stomach, if the patient has gastroesophageal reflux, if there is an overlap of small bowel activity with the stomach region of interest, a prolonged time for the patient to ingest the meal, lack of attenuation correction, particularly in obese patients, failure for the technologist to recognize that the patient has not eaten the entire meal, lack of decay correction for the tracer used, or failure of the patient to ingest the entire meal. This chart lists the normal limits for gastric retention for a 4-hour gastric emptying study. Additional imaging is sometimes warranted. If aspiration of gastric contents is suspended, radioactive markers are placed for anatomic reference. Once the meal is completed, an additional non-radioactive liquid feeding is given to clear any remaining radioactivity from the esophagus. Images of the thorax are obtained immediately after ingestion as a baseline, and serially for 60 minutes thereafter. Radioactivity seen in the lungs confirms the diagnosis of aspiration. This is an example of an adult drug-induced aspiration. Aspiration of gastric contents sometimes requires special administration. An administered activity of 0.5 millicuries of technetium-99m sulfur colloid is placed in a small amount of the patient's feeding, a bottle in infants and children, by a nasogastric tube or by a gastronomy tube, depending on the clinical situation and in consultation with the referring clinician. If the material is administered orally once the feeding is completed, an additional non-radioactive liquid feeding is given to clear any remaining radioactivity from the esophagus. Images of the thorax are obtained immediately after ingestion as a baseline and serially for 60 minutes thereafter. Radioactivity seen in the lungs confirms the diagnosis of aspiration. Imaging is terminated after the radioactivity has cleared from the stomach. This is an example of pediatric aspiration after meal ingestion. In infants and children, evaluation for aspiration of gastric contents is included as a routine component of the radionuclide gastric emptying study and GE reflux exams. Gastroesophageal reflux refers to the symptoms of heartburn, regurgitation, and chest pain. Esophageal reflux occurs when either gastric or duodenal contents enter the esophagus. Lower esophageal sphincter incompetence must be present for reflux to occur. Some of the anatomic abnormalities that can result in lower esophageal sphincter incompetence are enlargement of the diaphragmatic hiatus, disruption of the phrenoesophageal ligament, loss of the acute cardioesophageal angle of His, loss of the gastric mucosal rosette, or a change in the distal paraesophageal pressure from an intra-abdominal to an intrathoracic level. Factors that can cause depression of the lower esophageal sphincter pressure are fats, alcohol, chocolate, and cigarette smoking. Consequences of recurring gastroesophageal reflux are esophagitis, unrelenting heartburn, and eventual dysphagia. This is an example of gastroesophageal reflux seen in a 9-month-old infant after ingestion of technetium-labeled sulfur colloid formula. This is a second example of gastroesophageal reflux seen throughout the dynamic imaging phase of a gastric emptying study. Interpretation criteria is as follows. The consensus guidelines are listed here. If a portion of the study is acquired continuously displaying these images in a cine format, it may better demonstrate the gastric anatomy. This is useful for certain conditions. In the evaluation of esophageal reflux, to evaluate whether there is an overlap of small bowel in the gastric region of interest, and also to evaluate possible movement of the gastric contents outside the drawn region of interest. Although continuous data collection for a portion of the study is not a part of the standardized protocol, many institutions may continue to use it for a portion of this exam. Static images should also be used to evaluate esophageal reflux. The patient's history is an important part of the interpretation criteria. Prior surgical procedures and current medications should be obtained before the study and considered during the interpretation. Reference values do not apply to patients who have had gastric surgery. When reporting, any medications being taken by the patient that may alter gastric emptying should be documented, as well as symptoms the patient experiences during the exam. And those symptoms are compared with symptoms typically experienced by the patient. The meal, imaging protocol, and technique for analysis should be outlined. Included should be any difficulties with ingesting the meal or any variations from the standardized protocol. Reporting should include the percent of tracer retained at the specific times after meal ingestion. The gastric emptying data should be compared with the reference values. A description of the pattern of emptying may also be helpful. The study should be compared with previous studies if they are available. If previous studies' protocol differed from the current protocol, this should also be noted. By following the consensus guideline for adult gastric emptying studies, we can improve the reproducibility of this imaging procedure and minimize errors. Standardized patient preparation, meal preparation, and ingestion parameters are key aspects of these guidelines. Thank you for joining us today. We hope you enjoyed our webinar on radionuclide gastric emptying. Please do not forget to take your test, and remember, you must score an 80% or above to receive a certificate.